بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين محمد وآله الطيبين الطاهرين. Today we have the first lecture in surgical syllabus in Basra University College of Medicine. I am Dr. Amr Salman, consultant plastic surgeon and assistant prof of plastic surgery. Wound healing is the first topic that we're going to discuss. It is a basic science topic which if you find it in the books, you're going to see it is a very difficult topic and with a lot of details and a rough subject which is difficult to be understood. Today I tried to modify this topic from this difficult material into a more simple way of understanding. I will try to change it into a story of wound healing. To start with, in definition, wound healing is the repair or reconstruction of a defect in an organ or tissue, commonly the skin. Reconstruction or repair means building. So the body is going to build back the organ or the tissue by the process of wound healing. To understand that well, we should know that a wound healing process is not a simple one-way repair. It is rather a spectrum of events, and it is have many different ways of healing according to the tissue and according to the type of injury. At the end of these spectrums, we have two things. One side of the spectrum, there is scar formation, which is the unwanted end result because the tissue is going to be replaced by scar tissue, and this is not natural. And the other way is other end of the spectrum is regeneration, which is returning the tissue and the organ into its original shape and structure. So regeneration is the preferable way of healing, and scar formation is the unwanted way. And in between them, there is a lot of mixture between them. Some tissues have little scar formation and a lot of regeneration. Other tissues have little regeneration and a lot of scar formation, and that depends on the type of tissue and type of injury. An example, neural injuries and skin injuries mainly characterized by scar formation, and that causing the tissue not returned to its natural function and look, and that's important. And on the other side, hepatic tissue bone injuries have a high percentage of regeneration, and that may return the function and the shape of these organs into their natural look. In our story of wound healing, we have three chapters of this story. The first chapter is the inflammatory phase, and the second chapter is the proliferative phase, and the third chapter is the remodeling phase. And these chapters are not clearly separated from each other. They are intermingled, they are connected together, and there is overlapping between them. There is no clear separation in the reality between these phases, but these are discussed in this way in order to understand wound healing process. The first chapter of the story of wound healing is the inflammatory phase, as we said, and this starts from the beginning of the injury and continue up to the first week of after injury. The example of wound healing here is the skin in this lecture. So we're going to speak about the wound healing in the skin as an organ or tissue. If the skin have been subjected to an insult and there is breakage and there is a break in the skin, the first thing that occur is bleeding. And this bleeding is the first step of the wound healing process. How can that occur? By the conversion of fibrinogen, which is present in the blood, into fibrin matrix, which is a jelly-like material that's going to fill the gap inside the skin in order to eliminate any dead tissue, any dead spaces there. They're going to be full with this blood clot. This blood clot represents the first step of the wound healing process, and it is the first part of the inflammatory phase. This blood clot is very important theoretically and very important clinically. Why? Because it fills the gap in the wound. The fibrinogen is going to convert into fibrin matrix, which is a jelly-like material that fill the space, providing a scaffold, a place that the cells can migrate into and can do action and can start their work to repair the wound. The other thing that the clot provides is the cap of the wound or the ischium of the wound, which is the top layer, which is the hard layer on the surface, which provide the wound with a watertight seal, preventing any new invasion to the wound from the environment. There is no bacteria passing, there is no fluid passing from outside to inside the wound by this cap. The clinical importance of that is don't play with the cap of the wound, please. Leave it in place. Don't remove it. It is important as a seal for the wound. Some patients try to remove this cloth from the wound. They they think it is something not important, but it is very important because it is the temporary seal of our wounds, and we need it to stay there to protect our wounds from any bacterial invasion. What occurs later? After the first 2 days, the neutrophils start to invade the fibrin matrix, and this neutrophils is very important cells because it have a phagocytic activity and it's going to remove the bacteria from inside the wound. The other important cells that's going to enter to the wound also after the second day and start to increase in number after that time is the blood monocytes. These blood monocytes going to migrate from the capillaries and going to enter to the wound, forming what is called the macrophages. These monocytes convert to macrophages inside the wound, and they are the key players of the wound healing process. Why? Because they have two important actions. The first action is phagocyting the bacteria and the necrotic tissue, cleaning the wound, scavenging the whole debris from the wound, converting it to a clean wound, number one. And number two, they are the managers of the wound healing process. They are the controllers of the wound healing process by chemotactic activity. They are going to secrete materials that organize and control the mobility of the cells, the amount of cells, the type of cells that's going to enter to the wound is controlled by the macrophage. So the controller and the manager of the wound healing process is the macrophages. Absence of macrophages from any wound will affect the final wound healing process. Other cells like lymphocytes and mast cells is going also to enter to the wound, and they have also some roles in the wound healing process. So the inflammatory phase is the phase of hemostasis and phase of removing the devitalized and dead tissue, and this phase of cleaning the wound from any microbial invasions, pathogens. All these things are in preparation of the rebuilding process or the reconstruction process. As we said, these phases is not there is no clear cut between them. The inflammatory phase continues up to 7 days after the time of injury, but that does not mean that the other phases is not starting. The second chapter of the wound healing process is the proliferative phase. It starts after 4 days, and sometimes some steps is earlier than 4 days, and it continues up to 21 days. This phase is the phase of building and reconstruction of the wound. What occurs in this phase? The first thing that occurs is in the epithelial layer, and the basal layer of the skin starts to change. The cells in this layer, in the basal layer, start to separate from each other, and the desmosomal connections is going to be breakdown, freeing the cells on the margin of the wound. And that helps these cells to proliferate and to migrate in order to form a sheet covering the wound in order to seal the wound and protect it from the environment. As we know from the inflammatory phase, the ishar or the cup was covering our wound and protecting it from water or any fluids from entering into the wound and from bacterial invasion. So we need to replace this temporary cover with a permanent one, and that is going to be done by the proliferation and migration of these basal cell layers from the dermis, and it's going to form a complete sheet that's going to cover the wound in a permanent way. This process starts sometimes 2 days. It starts immediately after the injury, and some kinds of wounds it ends within 2 days only. So we need sometimes 48 hours in order to have the wound to be completely sealed by these cells. This is important clinical fact. Why? Because this determines the time that our patient can have shower after surgeries or after any kind of wounds. Is the patient's wounds ready to have water on it, water, soap, anything on it? This is determined by the time of reepithelialization. If we have a simple wound, if we have perfectly closed surgical wound, these wounds is not going to take more than 24 hours, not more than 2 days in order to re-epithelize. And re-epithelialization means a permanent sealing of our wound. So there is no invasion of any microorganisms, no invasion of any fluids from the exterior to the wound. And that is a clinical importance to allow our patient to have shower after 2 days of surgery. And this is important thing to be remembered and important practical thing to be told to your patient after having surgical wounds. The next thing that occurs in the proliferative phase is the proliferation of the capillaries. All the capillary ends surrounding the wound is going to have buddings. It's going to proliferate to have buddings and to divisions and forming new capillaries and new vessels, which is called angiogenesis and vasculogenesis. These capillary buddings and capillary proliferation and capillary invasion of the fibrin matrix is very important in the wounding process. It's like building highways in the city. It's going to provide a route for entrance of the cells to the whole area of the wound and entrance of the nutrient materials, entrance of all the things that needed in the building of that wound. This is the first step. The second step is the entrance of the builders, which is the fibroblast. The fibroblast is the real builder of the wound. Why? Because the fibroblast is able to lay down collagen, and the collagen is the basic material for building any of building skin matrix. The first thing that the fibroblast is going to lay down is the type 3 collagen, which is a weak type of collagen, allow the wound to stick together, allow to fill the space easily and easily to be laid down, but this is not the final thing. It is the intermediate phase of building. So we have capillary buddings, angiogenesis, vasculogenesis, plus collagen laydown and fibroblasts. These combinations are called granulation tissue. The granulation tissue is going to fill the wound in the proliferative phase and is going to replace the fibrin matrix that occurred because of the clotted blood. So we have in the proliferative phase, instead of the fibrin matrix in the inflammatory phase, we're going to have a granulation tissue in the proliferative phase, which is capillaries plus fibroblast plus laid down collagen. All this process, as we said, is controlled by the macrophages. And there is a point in this process when the whole wound is filled with collagen. This is the point that the macrophages should give signal to all the cells to stop proliferation, to all the cells to regress and to get out from the wound in order to finish the building process. This is an important signal that should be sent from the macrophages, and the signal depends on filling the wound with the collagen. If the wound is filled with collagen, the macrophages will say to the cells, please stop laying down more collagen, please go out from the wound, capillaries stop proliferation, regress, and close the roads in order to finish the process of wound healing. Proliferative phase ends after 21 days, and after it we are going to enter to the third phase of the story. The third phase of the story is the remodeling phase, in which it starts after 21 days, especially after the signal of stop from the macrophages, when the wound is filled with granulation tissue and all the collagen is laid down. The macrophages will stay stop, the fibroblasts will regress, the capillaries will regress, and there is a new thing going to happen to this wound. The important thing is going to happen is the collagen remodeling. The collagen type 3 is not a strong kind of collagen that can hold the strength of the wound and protect the wound from reopening. So we need a stronger kind of collagen. The collagen type 1 is the definitive and the final collagen that should replace the collagen type 3 in order to make the wound stronger. And that is the main thing that occur in the remodeling phase. The other thing that's going to occur in the remodeling phase is the entrance of the myofibroblast to the wound in order to reduce the size and the dimensions of the wound. And this is of a clinical importance also. Because these myofibroblasts have a muscle-like action, because the configuration of the cell is different, they are able to pull the sides of the wound narrower, and it will reduce the length of the wound. After full wound healing, the length of the wound will be shorter, approximately with 10%, and that is of very clinical importance. If we know that our wound is going to be shorter by 10% after finishing of healing, that means there will be some contraction of the wound, and this contraction is going to have a very bad effect if these contractions are crossing joint surfaces. So the flexor surface of any joint should not be crossed vertically by any wound, because the wound is going to be shorter. And if the wound is going to be shorter, that will produce contracture in that wound, in that joint, and will limit the function of that joint. And this is important clinical point that we can take it from this lecture. The other important thing is the tensile strength of uh, the wound. In the start of the wound is very weak, and we put stitches in order to hold that wound together. After 3 weeks from laying down collagen type 3, the wound's going to have a 20% strength of unwounded skin, and that is a very weak strength, and it cannot withstand a lot of forces, and the wound can easily be reopened. So, but in that time, before that time, in 2 weeks, we should remove all the stitches. The stitches was going to have a bad effect on the body if we leave them for a long time. So we are going to remove the stitches while our wound is not in full strength. And how we are going to deal with that? That needs an explanation. It's going to be present in the next lecture. In the end of the remodeling phase, the wound is going to have only 70% of its full strength, and that means the wound didn't return to its normal characters. And this comes from the fact that this process of wound healing depends on scar formation and not regeneration. If regeneration occurs in the skin, the strength of the wound should return to 100%. But it is a scar formation, and the scar is weaker than the normal skin by 70%. Thank you very much. In order to clarify some practical point, we asked question in 2016 to our students. It was a true and false question. As revitalization process rapidly occur in wound healing, can the patient take a shower after 21 days from the surgery? What do you expect the answer? Is it true or false? One of our students have answered me in this way. The answer was, as the wound healing process takes 1 to 2 years, the patient should not shower for that period. I think the patient after 1 to 2 years will look like this guy. There is factors that can affect wound healing. There is a lot of factors in this slide that can affect wound healing. All of these are important to be considered. And these are examples of abnormal kind of wound healing. This is a case of hypertrophic scarring in which there is widening of the scar in the lip. And this is a case of a keloid wound healing, which is an abnormal wound healing. There is elevation, there is redness, there is extension of the wound to the margins, extension of the healing process beyond the margin of the wound, and increasing the size and elevation of that wound. This is itchy, painful, causing cosmetic problems to the patient and functional problems. These are also a keloid that have been excised. This is a keloid also after surgery. We have to differentiate between hypertrophic and keloid, which is the two abnormal wound healing processes. Hypertrophic occurs before 6 months. Before 6 months means that the patient, if the duration after the injury is below 6 months, this is possible to be a hypertrophic or can be a keloid. It can be both. But after 6 months, it is only a keloid abnormal wound healing. The hypertrophic is limited to the wound age, but the keloid extends beyond the wound age. Hypertrophic resolves spontaneously and does not need extensive management, but keloids needs very strict regimes of management and long duration of management. Everybody can have a hypertrophic scar, but keloids usually hereditary and runs in families. Hypertrophic scar does produce wound contracture, but keloids is less likely to produce wound contractures. And thank you.